differences. You're welcome to today's echo session. We would like to recognize our co-hosts. I echo India. I can see Alina is already here. Then, of course, the project manager, NSIC Nigeria, Chiamaka, is also on the call. I'm trying to see, have our honorable guest speakers joined us yet? I would like to make welcome all those who have joined so far. We don't have a long list, so I can just recognize a few people. I can see Nafisa, Khalid. We have two Khalids. Is it the same Khalid using different devices? Then we have Bakobi, Abdul Fattah, Naghama. You're all welcome.
Thank you, ma.
Today we are discussing a very important topic. A couple of months back, we talked about the cholera outbreak that seems to be a scourge with us in country. I know that one of the major issues with having outbreaks each year have to do with WASH. We also are aware of the fact that WASH and IPC should I say they are twins, Siamese twins. You cannot separate them. Without WASH, IPC will not succeed. So we thought it wise to have two very important people discuss to us about WASH. If you look at the program which has been put up, Dr. Ezema Chuebueze-Godian will be taking us through WASH and IPC in healthcare facilities. So what is the link between WASH and IPC? Why is WASH so important for you to have a successful infection prevention and control program? And we know that WASH stands for the acronym Water, Sanitation and Hygiene. Sorry, I didn't even inquire. Am I doing head clearly? I just continued.
We can hear you. Yes, go ahead. Yes, you can hear you.
Yes, we can hear.
So what's the link between WASH and IPC? And as I said, WASH stands for the acronym. WASH is the acronym Water, Sanitation and Hygiene. So we're going to find out from Dr. Ezema Chibueze-Godian, who is an experienced public health consultant that will take us through this. And we have Dr. Ekuma Egantem, who will be sharing with us his facility experience. So let me confirm if our speakers are with us, then I'll get back to you. Once again, thank you all for making time to join us.
John, I'm here. Good afternoon. I hope you can see me and can hear me.
My brother, I can hear you. Thank you. I was just trying to scroll through the list before I heard your voice.
I know. Right.
So, ladies and gentlemen, permit me to introduce Dr. Ezema Godian, who is a consultant, community public health physician, and an IPC practitioner. He has over 2 decades of field experience in public health practice, both locally and internationally. He has areas of expertise, and research include community health development, community mental health, infection prevention and control, infectious diseases control, health program management, and management of vulnerable groups, such as internally displaced persons. Dr. Ezema Godian is a fellow of the prestigious West African College of Physicians and member of other professional bodies, such as Association of Public Health Physicians of Nigeria, Nigerian Society for Infection Control African Network, and Nigerian Medical Association. He possesses a postgraduate diploma in psychology from University of Nigeria, Nsukka, and a Master's of Public Health International from the University of Leeds. He also has a professional diploma on infection prevention and control from the University of Lagos. He has certificates in quality improvement by the Health Qual International, Management and Sustainability of Project Programs from African Medical Research Foundation, Nairobi, Kenya, and is a host of other certifications. He has attended many conferences and seminars, both locally and internationally. Dr. Godian has been honored with various awards, locally and internationally, some of which include Leadership Excellence by Rotary Clubs in Ebonyi State and Best Exemplary International Doctor in East Timor. He also holds the Ruth Griffith Prize for the Nuffield Center for International Health and Development, University of Leeds. Dr. Ezema loves sports and is happily married to Honorable Justice Beatrice Ada Ezema. Please, let's make welcome Dr. Godian Ezema. Dr. Godian, you have the floor.
Thank you very much, my senior.
Are we sharing your slides or you are projecting from your end?
Either I can share or you can share. Which one?
Which do you prefer?
I usually prefer to share my slide, but you can do that, no problem.
Okay.
Did I share or are you sharing?
Yeah, I was waiting for the admin.
Okay.
To take up sharing the slides. Okay.
Please, are you able to see the screen?
Yeah, it's not it's not yet in presentation mode.
It's not in slideshow.
All right. Are you able to see it now?
Yes,
all right, great.
We are good to go.
All right. Thank you.
Thank you. Good afternoon, everyone. Like my senior and colleague in IPC have rightly said, I'm Dr. Ezema Godian Chibueze. We'll be looking at the WASH and IPC in healthcare facilities this afternoon. So we can move ahead. Next slide, please. Sorry, next slide.
Yes, I'm moving it. It's moving. Okay.
Okay. If it's becoming difficult, I'll do it myself. Go ahead. We'll be looking at the outline we'll be using for this presentation today includes objective WASH in healthcare facilities, importance of WASH, what is IPC, WASH and IPC, why WASH for IPC, challenges, then improving WASH and IPC, then we conclude. Next slide. As our objective for this presentation, we aim is to define and understand what is WASH, which stands for Water Sanitation and Hygiene, and as well understand the role of WASH in IPC, and then look at the interaction between these two words. So I will start first of all by defining what is WASH in healthcare facilities. Next slide, please. The term WASH in healthcare facilities refers to the provision of water, sanitation, healthcare waste management, hygiene and environmental cleaning infrastructure, and services across all parts of, yes? Sorry. Sorry, I thought the person was referring for me. I think somebody is not muted. Please mute your mic. Yeah, I can proceed. So now what's the global, I think, can you hear me clearly now?
Yes.
We can hear you clearly. Please
Sorry
go
about
on.
that. Local action. Somebody was speaking. I thought he was referring to me. Okay.
Sorry.
So let's look at the global status of WASH services in healthcare facilities. We know that based on the reports, we have over 1/3 of healthcare facilities lack infrastructure needed to clean hands. That's the problem, you know. So, and 1 in 4 lack basic water services. So as I'm saying, you can look back on where we work and see how actually this relates to where we work. And then 1 in 10 have no sanitation services, you know, toilets and so on. That's globally. And approximately 1.8 million people use facilities that lack basic water services entirely. So you look at after 7 billion point on earth, 1.8 billion people lack this use facilities without basic water services. And approximately 800 million people use facilities with no toilet at all. And we are not talking about adequate toilet, we are talking about no toilet. So, and when you look at the least developed countries, you find out that 50% of healthcare facilities lack basic water services. When we are talking about 1 in 4 in global, you've seen, but in the least developed country, 50% of them don't have basic water services. And then worse still, we have a major gap existing in data, especially in environmental cleaning, for us to make informed decision or to actually know the extent of the problem. So graphically, if you look at the next slide here, we see the least developed countries, what is the situation like? Like I have said before, in terms of basic water services, 50% only. Then you look at the basic sanitation, 37% only has sources for toilets and so on. And then hand hygiene, as much as 74% is the gap we have. While in the basic health care waste management, almost 30% gap we have. And then in environmental cleaning, like I said before, we don't even have enough data to actually ascertain the extent of the problem globally. This is as reported by the WASH. Now, when we look at our own environment, what is the condition of WASH in our facility? We all work in healthcare facilities or attend healthcare facilities. When we look back, even teaching hospitals, even federal medical centers that are supposed to be centers of excellence, what is the situation in our facilities? You go to teaching hospitals, you see them carrying a tanker to bring water, and then you see the water wasting outside. You come inside the water to wash your hand, you open the tap, it's not running. They'll tell you, sorry, 1 pipe got broken. We have reported to the works, and up to now, nothing has been done. This is the situation we have. So even when the water is in that environment, even when there's borehole, even when there is a facility that has even water treatment plant, how do we source that water in the place where we give health services? That becomes a challenge. Where do we have enough? Do we have enough water in the toilets? Some places you go, you see water in the down floor, and these are 2-story buildings. You climb the story, the stairs, no water there. Somebody have to carry water from bucket from down up before a patient could use the toilet. So these are the situation we have. Then let's look at what is water fit. WASH fit, I mean. The WASH fit represents what we call the Water and Sanitation for Health Facility Improvement Tool. And this is the WHO tool, which is a risk-based management tool for healthcare facilities for improvement in specific areas such as water, sanitation, hand hygiene, environmental cleaning, healthcare waste management, and selected aspects of energy, building, and facility management. So it's a tool that will guide us or help us to improve water and sanitation in our environment. And it provides a framework to develop, monitor, and continuously implement an improvement plan and prioritize specific WASH actions that are climate resilient, equitable, and inclusive, and supports the implementation of IPC standard and transmission-based precaution in all our health facilities. And also, WASH Fit is actually an interactive quality improvement methodology to improve wash services in our health facilities. So it's a collaborative, it's a tool that helps us to have intersectoral collaboration in terms of improvement of wash in our health facilities. Next slide. Now, this is the overview of the wash fit. If you look at this diagram, you see by the left, you have the resource inputs. What are the resources that are required for the improvement or having a sustainable wash system in our hospitals? You see, in the left hand, you have the political, you have the financial or material, you have the human resource, you have the civil society engagement, then you have intersectoral collaboration and energy, and climate and health. So these are the inputs. You have political is very key, because without political will, we cannot achieve. And this political will includes both the politicians in the government sector and also the leadership in our own facilities. This will help them to even have budget and allocations for WASH and IPC in the health facilities. In many facilities, WASH, they don't have budget allocation, allocatory budget for WASH and IPC, and that's a challenge. And it's only when we have these inputs that we can be talking about the cycle of management, which is, first of all, we have to have established and train the team that will actually work for this WASH and IPC in the facilities. And then this team will be able to have an assessment of the facility need, what actually is the gap, then be able to identify and prioritize where they will handle or where they will tackle in terms of improving WASH in the facilities. And then when you have identify the priority, you'll be able to implement, then take action, you implement, and then make sure that what you have prioritized, you don't, then you monitor and then review and learn, and the cycle goes along. And then the outcome will lead to what improved infrastructure, services, and facility management, which includes improved staff morale and performance. If you go to a hospital where the patient staff will tell you that they don't even have water to wash hands, it's demoralizing. Even when you want to do the right thing, you can't do it. It is quite demoralizing. And you come to the facility, everywhere is messy, it's smelling. Nobody wants to be in such an environment. Even the patients themselves would not like to find in that health facility. And I know a lot of patients that don't want to go to the hospital because of the smell they see in the hospital. So if you have lack of water, certainly what we're talking about, universal health coverage, increasing access to health, is a mirage, cannot happen. Then without also water and sanitation, IPC is a mirage. You can't expect for IPC to occur in the absence of water and sanitation. You must have enough water to be able to wash hands, to be able to clean the environment, to be able to clean the linens, the tables, and so on and so forth. Without that, every other thing you are doing is a mirage. And then the long term, what is the aim, the benefit of this? By the time all this is implemented, you have this quality, equity, and dignity. People will now come to hospital. They will no longer stay in the hospital for infection they contract because of dirty environment, because of poor hygiene, because of poor IPC practices in the environment. Next slide, please. The next slide will be telling us, the next slide, we'll be looking at this practical step for improving. Sorry, I think I'm not seeing the slide anymore. Hello? Or do I share from my side?
Maybe her network has taken her out.
Yes, my network kicked me out. So, but I want to start sharing again, please.
Okay,
Sorry.
now. So I'll just be speaking while you share. You have 8 practical steps. I'm hoping that before I finish saying that it will be projected up. So this practical step is what we need to improve and sustain wash services in practices in healthcare facilities as enumerated by the WATFISH. The first one is situational analysis and assessment. You must have to have proper assessment of what is actually the situation in the country, in the facility, in country, and globally. If we don't, we will not be able to do proper budgeting for what we need to tackle. And then secondly, we should have national target and roadmap. If we don't have national target and roadmap, virtually we'll not even know where we are heading to. They said that if you don't know where you are going, you may not know where you when we have arrived. Then we have to have national standards and accountability mechanism, which is very key, because if there are no accountability mechanism, policies that we produce may not be utilized, or if there's no checkmate, how do we guide the utilization of these policies? That's very key. The fourth one is infrastructure improvement. We must actually start looking at the infrastructure we have. What is the gap in infrastructure improvement? What kind of taps do we have? Is this tap in agreement with the IPC policies? Where is the water, the source of tap? Where the water running? Is it where the point of care? How accessible is it in point of care? What kind of infrastructure do we have to develop in order to suit the kind of healthcare services we want to render? Then we need to have data. Data is key, because data speaks. Without data, you will just be moving around. You need to start gathering data, reporting data, be able to use data to make informed decision. Then current workforce is very key in terms of WASH and IPC. Without health workforce, we have to analyze which category of healthcare workers do we need, what training gap do they need, what training do we need to give them for us to be able to say, yes, we are where we are supposed to be. Then we need community engagement. Community engagement, including the politicians, the management of the facilities, every key stakeholder, we need to engage them to see the importance, because when we go with data and engage them, they will be able to see the gap and see the direction where we want to go and what we want to do. Then operational research and learning. This is very key. We must have to do research, operational research, to see where is the gap, what are we doing, what's the benefit. And this is in consonant with the core component of IPC, because if there is no research, if there's no operational research, we may not be able to know the direction we need to go, because this operational research that tells us that antimicrobial resistance is increasing in these areas, and this is what is happening. This is what we can do to intervene, and that is very essential. If you look at the point number 5 also, it relates with the SDG number 6.
Dr. Isama, it's like we're losing you.
Okay, can't you hear me well?
It was going on.
Hello?
I can hear you now. I can hear you now, yeah.
So I think it's my network then. Apologies for that. I don't know where you stopped hearing me. Okay, but let me just continue.
Yes,
okay,
continue.
Okay, fine. Okay, fine. So if you look at the number 5 actually speaks closely to the number 6 goal, the 6th goal of the SDG, which is water and sanitation for all. It is very, very key. So whatever we are talking here is what is global importance in order to improve health for everyone. Next slide, please. Now, let's talk about what is IPC, because since I've been talking about, I'm talking about WASH, and we are looking at what's the importance of WASH in IPC. So IPC is a scientific approach and practical solution designed to prevent harm caused by infection to patients and healthcare workers. It is grounded in infectious disease epidemiology, social science, and health system strengthening, and occupies a unique position in the field of patient safety and quality universal health coverage, since it is relevant to health workers and patients at every single healthcare encounter. This is what WHO defined IPC as. So for IPC, it's at every encounter. Anytime you meet a patient, what will you do to prevent transmission of infection, to minimize the chances of this patient getting infected because of the services we are rendering? That is what we mean by IPC. Then let's look at what is the relationship between WASH and IPC. Next slide, please. Now, fully functioning water, sanitation and hygiene is very crucial. Without that, forget it, you can't achieve IPC. How do you wash hands when there is no water? How do you do IPC when there is no sanitation? How do you do IPC when you cannot manage your waste properly? All right, these are very crucial. WASH and IPC were the statement. I remember when we were doing our course, they would tell us that IPC and WASH is like the hardware and software, where the WASH is the hardware, the software, and the IPC is the hardware. You cannot separate these two. Without WASH, IPC is a miracle. There's no way you say, I'm achieving infection prevention and control without WASH being there. Both of them are interwoven. You cannot actually separate both of them. They are like the spirit and the body. When one of them is not there, then a person is not complete. You can only say you are a human being when you have the spirit and the physical body. And that is exactly what happens in IPC and WASH. No health services can never be safe, can never be equitable when both of them are not properly taken care of. Next slide. So the simple question we will ask ourselves, why do we need WASH for IPC? I have almost answered the question, but I would like all of us to sit back and think, can we really achieve IPC without WASH? Can we offer quality healthcare services without WASH or without IPC? Is our health facilities, is they going to be safe for patients that are coming without WASH or without IPC? Can we do one without the other one? So the answer certainly is no. So you now see that WASH and IPC are the different faces of the same coin. So by the time you say separate the two, it becomes very difficult to separate, but it's always better when you bring them together. Next slide. So what do we need WASH for IPC? Why do we need WASH for IPC? WASH intervention are often combined with IPC intervention for such as hand hygiene, cleaning and disinfection, waste management, linen management, needle stick and sharp injuries. These are all integral. I went to a facility where I saw a heap of these sharp boxes. All right, there are more than thousands of them. They used in immunization for years. What is the problem? They couldn't know what to do with them. There is no incinerator. So can you achieve adequate infection prevention and control? Imagine when I went, one of them, the roof was leaking and it is pouring on these sharp boxes and they were all getting soaked. And then what happens? They would certainly melt away and we see these sharps everywhere, exposing people to infection. So you notice that IPC interventions are not practicable without WASH. And we cannot achieve IPC without WASH services. It's not possible. And then also, without adequate WASH, there will be the morale of healthcare workers, including the people who are coming to access care, is very low. And it will definitely reduce this health-seeking behavior of our clients. They would not like to come there. Nobody wants to come to a place that is littered. Nobody wants to come to a place you come and you see rub stains everywhere. Nobody wants to come to a place that after going to the toilet, he cannot flush the toilet. He can't wash his hands. It's not possible. So this, and you see that we really need WASH at all times if we really want to achieve IPC. So what are the challenges? Next slide, please. What are the challenges? The challenges I've almost mentioned, many of them, is poor infrastructure. Water supply is an issue. Sanitation facility, very huge equivalent ties in this part of the world. Hand washing stations also is a problem. Most times we construct hospitals without taking into consideration the hand wash stations. So this time around, most of the facilities we start making makeshift hand washing stations. These are something that's supposed to be incorporated during the design of health facility. But most times the potentials we build without even consulting professionals, and that's the problem. Funding is also a very crucial challenge we have. How many facilities have budget for IPC? How many facilities have budget for WASH? They don't. It is ad hoc. When they hear that, WASH, call the works. What can we do? There is no budget for maintenance. There's no budget for WASH. The research of it. When the waste management also is an issue. People will build fantastic hospital, big hospital, state-of-the-art hospital, no incinerator, no waste management plan. It's a problem we have in this kind of part of the country. Leadership and commitment. It's only now that most of our managers in the health system start understanding what is that WASH, what is the importance of WASH. Previously, it's not there. You have to convince them, talk to them, talk before they even listen to you and see that it's something that is relevant. Monitoring, we don't even monitor what we do. Many facilities don't even have IPC team, not to talk of committees. They don't have. So who monitors what is going on? Who monitors the extent of injuries, sharp injuries? Who monitors the AMR, antimicrobial resistance in the hospital? Nobody. In many occasions, there's no system put in place. Nobody monitors anything. So everything goes. Somebody will come to the hospital, acquires another illness in the hospital and goes. Nobody even knows. If not because of Lassa fever, it came and started killing some healthcare workers. We don't even care what happens. So it's just a problem we have. The maintenance, even when those infrastructures are built, who maintains them? You go to a hospital, you see taps dropping water for weeks and nobody cares. You see the broken taps, nobody cares. Maintenance culture is just a problem. We need to start looking into those aspects. It's not just coming to consult. We sometimes, as doctors, as healthcare workers, we think our work ends with stethoscope and writing. No, the environment is very key. It's very crucial to whatever we do. Training and awareness is very, very crucial. We must train people. We must create awareness in terms of WASH to everybody that need to know. Those who are small junior staff today, those medical officers may become the CMD tomorrow. It is from now we start inculcating that culture into them. And there's urban-rural disparities. You go to many rural hospital, there is no single water. They don't even remember that it's important. If you go to our primary health centers, general hospitals in the rural areas, on the local government, nobody talks about water. It's as if it is something of coming from another planet. It's a very big issue we have in this country that need to be handled and tackled. Then in terms of IPC, the next slide, please. What are the challenges in IPC? Similar challenges: inadequate resources, insufficient training and education. When we talk about inadequate resources, including human resource for health, how many of us are professional infection prevention control professionals, practitioners? We do have very few of them. It's recently, some of us are fortunate to have gotten that education. Previously, you find that everybody thinks that IPC is just about washing hands and nobody cares. That's one of the key challenges we have. And we need to start looking at how do we build a bank of adequate human resource for health for IPC and WASH. Insufficient training, like I've said, and education is also a problem. The curriculum we have in the medical school, in the nursing school, how adequately is IPC and WASH covered? We also have, like I said before, same thing about WASH, inadequate infrastructure about WASH. Without WASH, there's no IPC that can be done properly. The compliance and monitoring, even when we have the policy guideline, how do we comply to this? Because there are no monitoring tools on ground for most hospitals to actually, especially in the secondary and primary health facilities, they are almost not existent. Then antimicrobial resistance is increasing and it's causing a lot of challenge for us. And it is now we need to start really talking about it. If we don't now, it will overwhelm us because even the antibiotics we have may not be relevant anymore, including cleaning agent we are using. The microorganisms are becoming resistant to them. And limited data and reporting, I've said it before, cultural and behavioral barriers. Sometimes people do not want to do the right thing because of the cultural or religious beliefs, all right? So sometimes we do not use appropriately the IPC protocols we are supposed to use because of those cultural barriers. When you tell people this patient needs to be isolated, the relatives say, no, I cannot run away from my brother. I cannot run away from my sister. They want to touch the person that have infectious diseases. These are some of the issues we have. Because the person says, it's my brother, it's my sibling. Well, how can I abandon the person? But you are telling the person, please use gloves if you want to touch this person. It's an issue we have. The funding constraint, we can never say this enough. We know what we have happening in the health system entirely, especially in our country, not to talk of when it comes to IPC, that's not even in the budget at all. The policy and government issue, we understand this. Mostly, there's no political will by the people who are managing us, and it is a problem we have. Next slide, please. Then improving WASH. What must we do to improve WASH and IPC in a health facility? We understand that we have to do what we call intersectoral collaboration. It is not one man business. It is not one sector business. It's not just the IPC practitioners. It's not just the nurses' job. It's not just the doctor's job. Everybody in the hospital, in the health system is involved, including the people who utilize the health system. We need to create awareness. We need to educate them to understand what they should do. What is their own contribution in terms of WASH and IPC in healthcare facilities? How do they utilize the water, the WASH tools we have in the hospital? Do they break the taps without caring? So we need to start thinking of that aspect. So we have to strengthen the health system. It's very key because a weak health system actually builds weak IPC and weak WASH. It's very, very important. So training and continuous training, we have to continue to train and retrain our healthcare workers to make sure that they understand the procedures, the policies, the guidelines for WASH and IPC. Very, very important. Then data collection and utilization, we now have to start thinking, having a process of gathering data, reporting them so that we can make informed decision with the data generated in the healthcare facilities regarding WASH and IPC. Then commitment by the government, healthcare institution and partners. We need to all come together, be committed to improve health seeking behavior of the people by making the healthcare environment and healthcare facilities attractive to them. If the WASH and IPC is poor, certainly people will not want to be in a place where they will come and get another illness. Imagine if a patient comes and hears that somebody was here last week and got Lassa fever in the hospital. Would that person want to come and be the next victim? Certainly no. So we need to start understanding that this is very, very key to all of us. Next slide, please. So because I know my time, I still have about 2-3 minutes. So these are the key take-homes in terms of summarizing what I've said. There is a huge gap in WASH and IPC in our facilities. I've said it a lot, and I'm sure all of us are aware of that. And IPC cannot be implemented adequately without WASH. It is not possible. Despite the huge challenges in WASH and IPC in our health facilities, proper collaboration among stakeholders will improve both. We have to collaborate. We have to work as a team. If we do that, we will achieve better health WASH and IPC. And then it is very important that for us to note that dirty healthcare environment discourages utilization. So we cannot be expecting our patients to seek healthcare in our facilities if that environment is dirty. Certainly they will not. That is the first thing that we push them away from accessing the health services. Then in conclusion, we say that together, IPC and WASH are critical to reduce hospital-acquired infections and essential for creating an environment that supports dignity and human rights. For our people, we must make the healthcare facilities clean and safe. There is no doubt about this. So thank you very much. I will not go without reiterating the statement by our DG WHO, who said that not only does the lack of WASH services in healthcare facilities compromise patient safety and dignity, it also has the potential to exacerbate the spread of antimicrobial resistant infections and undermine efforts to improve child and maternal health. This tells you how important this is. So it's not just about what I've said. Even the WHO DG have said exactly the same thing. And I am sure that if you are also allowed to speak, you will say the same thing I'm saying. So all of us must put our hands together to make sure that we improve WASH and IPC in our environment. Below are some of the references you can actually look at. Then we can ask our questions, and then I'm sure that the ones I cannot answer, I have my colleagues here, powerful people like Joanne and Co, that can help me answer some of these questions. Thank you very much, and God bless.
Thank you so much, Dr. Godian, for that wonderful presentation. You were able to pack a lot and deliver within the limited time. And thank you for reminding us of what the former DG of World Health Organization said. It comes to mind when you see the scorecard that you projected. 37% of facilities have basic sanitation, and we only scored, well, I think it was a good point. Hand hygiene was about 74% or so. In addition, one very important statement that you made is that IPC interventions are not practical without access to WASH. I'm sure many of us can have instances in our facilities, if we give time, for to share experiences or what goes on when it comes to WASH and IPC. And very important, the 8 practical steps of instituting WASH in healthcare facilities. So please, can we appreciate Godian for his wonderful presentation? We will take questions after our second presenter, who will be sharing with us his facility experience. So I would like to introduce at this point Dr. Agantem Ekuma, who is a medical microbiologist and IPC practitioner. He's currently serving as the IPC coordinator and chairman of the hospital IPC committee, University of Uyo Teaching Hospital, Uyo. He has been involved in IPC training and IPC response within the University of Uyo Teaching Hospital and across Akwa Ibom State. He's also a lecturer at the University of Uyo, and IPC and antimicrobial resistance and stewardship are amongst his major research interests. He has published several scientific papers in this regard. Please let's welcome Dr. Agantem Ikuma to share with us his facility experience. You're welcome, sir.
Thank you very much, moderator. And thanks to NSIC for inviting me to do this presentation. So, and it's indeed a pleasure to share with you what we've been doing as an institution in the areas of WASH and IPC. Next slide, please. Yes, so let me introduce my institution to you. The University of Uyo Teaching Hospital is a 500-bed tertiary hospital in the capital city of Akwa Ibom State, that is Uyo. And Akwa Ibom is in the south region of Nigeria. So in this hospital, we have about 25 wards, both medical and surgical. And we also have an accident and emergency center with also an adjacent pediatric emergency unit. So there are several outpatient clinics. There's an outpatient block, and then we have a few other outpatient clinics like the one for the ENT and eye, also in different parts of the hospital. We also have a laboratory complex, which is just about to be put in use. And we have other blocks like the one for the physiotherapy and so on. Next slide. Yes, so this hospital has an IPC program which has been in operation since about 2011, so making it about 13 years now. We've been running this IPC program. So you can see that we've had 2 editions of our infection control IPC policy. So the first one was done maybe about 2012 or so, and the current one has been in use since 2020, and it's available at, with this link on the hospital website, but it's actually due for a review, which we are currently in the process of doing. However, we have just one full-time IPC nurse, and she's supported by a community health officer, and we have a few other non-specialized staff working with her full-time in the IPC unit. So we have an expanded IPC committee, and incidentally, we just had a meeting this morning, which kind of coincided with this presentation. So the heads of clinical units, medicine, surgery, pediatrics, O&G are all members or represented in the committee, with also representation from nursing services, laboratory, theater, and environmental health, and other units in the hospital are well represented. It's an 18-man committee, so it's quite a large committee. So the IPC program is being expanded by the day. So this year we have a very robust work plan, which involves continuing education. So just like we've said in the previous presentation, training and retraining is a very important component of IPC, and that's exactly what it is for us here. So a lot of time in IPC is spent educating, informing, updating knowledge of healthcare workers, doctors, nurses, and every other professional, pharmacists, laboratory scientists, health attendants, and every cadre of staff in the hospital. In fact, there is a strong push for us to even extend to staff of the works departments. In our meeting, there's advocacy for that because they have to do work in the clinical area. So this is going on monthly, and I think so far it is really bringing a change in compliance to IPC protocols. So we also carry out supportive supervision in form of inspection and audit of wards. So we've designated all the wards and OPDs in our hospital for different months of the year, where we go and observe their level of implementation and compliance of IPC and all that. And then we also have statutory meetings like the one I've mentioned and others too. Next slide, please. Yes, so to our WASH infrastructure, the hardware, like the previous speaker mentioned. So over the past few years, maybe I'll say the past 4 to 5 years, there has been tremendous improvement in our water supply in the hospital. So the picture you can see on the slide there is the main water reservoir. So this is just the main water reservoir, but there are several others scattered across the hospital, smaller versions of this one, but this is the biggest one, which I decided to put on the slide. So to date, the water storage capacity is over 200,000 liters, and that has helped us to achieve almost total complete water supply in the hospital. So I believe the capacity can carry close to 48 to 72 hours even without additional pumping. So this regular supply has been improved due to improved power supply. So not too long ago, our hospital has been linked to band A of power supply, which has been a positive development for IPC. But it seems the finance people are saying is a negative development because their power bill has significantly gone up. But that's on a lighter note. So we also have in-house preparation of most of our disinfectants and detergents, including hand sanitizer and all that. And this has reduced the cost of providing these consumables for water and hygiene and has improved the supply. The other picture we have on this slide is a water treatment plant. So it's quite an effective system, which I taught recently in preparation for this presentation. So there is a system there that supplies chemicals for water treatment before it is pumped into storage and subsequently supplied to the hospital. So there is quite a strong and robust water supply infrastructure in the hospital. So, however, challenges still exist with regard to the quality of water. I think there is yet to be high confidence in the quality of the water, especially for drinking. So, and then the other challenge is plumbing. Plumbing is also a major challenge. I think maybe aging infrastructure requiring changes in plumbing, so you can see leakages into the walls leading to some kind of defacement. So, but I think efforts are being made in that direction to improve that. Next slide. So for healthcare waste management, which is an important component of WASH, so our hospital has been fortunate that sometime in the past, the hospital acquired this quite, well, I don't know if I'll be right in saying state-of-the-art incinerator. So it's a high-temperature incinerator with a large capacity. Unfortunately, I can't quote the exact capacity of the incinerator. So it is operational in our hospital, thanks to the management and also support from partners. It has been maintained and it's in use. However, there has been periods when it has not been used, largely due to lack of power, particularly when the hospital was being powered by generators. So hike in diesel prices sometimes made it not to be in use, but it's presently in use. So the IPC unit has been advocating and the management has supported us increasing the number of bins in the hospital. Then we have a picture here of some of the wheeler bins that are, or one of the wheeler bins being used for evacuation of waste to the point of final disposal. So they are part of our waste disposal infrastructure. There is also good supply of sharp boxes, which we've observed during our inspections of different parts of the hospital. So of challenges, include high costs of operation. Just like I've mentioned, high cost of fueling for operating this equipment. Also, maintenance too is an issue. There's a high cost of maintenance due to some challenges with use, particularly of the wheeler bins, since they have to be used to evacuate waste several times in a day. So maintenance is also a challenge. And then segregation has been a challenge for us as an institution, especially during times when the incinerator was not in use. So that has been a challenge, but currently being addressed by the IPC in association with the environmental unit. Next slide. So for environmental cleaning, yes, it has been in place all the way, but the IPC unit has been pushing a new paradigm, to emphasize the need for surfaces to be decontaminated on a daily basis. So that has been a new paradigm and a new method of environmental cleaning is being pushed. So there is orientation and reorientation to meet up with this. So like I mentioned earlier, in-house production of detergents and disinfectants has also helped to ensure that at least those consumables are available. And one new innovation that the IPC unit is in the process of implementing, is piloting in some words, is the use of a cleaning log. So this is just a record to ensure that cleaning of all areas has been done under supervision. So if the person who performs the cleaning fills the log and a supervisor has to sign, we believe that will improve the compliance and ensure that this cleaning is taking place and all aspects of cleaning are being adhered to. So we are currently piloting that across some wards of the hospital, and I think it's yielding some good results. However, I think maybe shortages of manpower have also been like an obstacle, which we are working to overcome. So these are just a few areas in which IPC and WASH are being improved in our hospital. The picture to the side is our hand sanitizer. Unfortunately, I didn't get pictures of all the other disinfectants that are being produced. We produce hypochlorite solution, chlorhexidine, and methylated spirit, and other disinfectants that are useful to ensure adequate sanitation of different around the hospital. Next slide. So in conclusion, there is constant improvement in IPC and WASH at the University of Uyo Teaching Hospital. The hospital management has shown a high level of commitment to maintaining and elevating infection prevention and control and water and sanitation and hygiene standard in the hospital. So let me just highlight before I conclude that, we in the IPC, we believe that it's an ongoing process, and that proper monitoring and evaluation needs to be put in place. A system of monitoring and evaluation needs to be put in place for the standard to be maintained, because it's very easy for the standards to drop when there isn't proper, because challenges will always come up. Stock outs of some of these items may occur and lead to drop in standard, lead to people ceasing to do what they were doing before, and that becoming the new normal. So for us, we see our role mainly as continuously monitoring, evaluating, giving feedback, and ensuring that higher standards are attained and maintained in this institution. So once again, I thank the organizers for inviting us for this presentation. Thank you very much.
Thank you so much, Dr. Egate. Please, can we give him a round of applause for sharing with us how beautiful his facility looks? Did you see that building? I feel like relocating to Uyo. And I'm a lover of pink. I love the color of your hand sanitizer. Ours over here is colorless. So well done.
Please
You
come
can see
up.
that your
We need you
facility
here.
is really doing a lot. So do we have questions for our presenters? But while I'm scrolling through the chat, searching for questions, let me start with Dr. Godian. Dr. Godian, I hope you are still with us.
Yeah, full time.
All right. There was something you mentioned among the challenges that I'm sure cuts across many facilities, the issue of infrastructure when it comes to WASH. In a very huge facility in northern Nigeria, just as you mentioned, they built a very lovely cancer center, and you'll be shocked to find that there's no single hand wash station in this center of excellence. How do we address these challenges with people, politicians, or even government bodies or non-governmental organizations that set up buildings within hospitals that do not meet standards?
All right. John, can you hear me?
Yes, sir. Loud and clear.
Thank you very much. You see, this is it had been a culture that politicians and organizations would, when they want to come and build, they don't really, it is this kind of push and not pull system. They don't even ask you. Once you say you need a ward, they will come to build the ward. They have a contractor who has no idea of the health system. I remember I went to a hospital. I saw a fantastic building from outside. And when I went there, I started laughing. I was with the CMD and I said, sir, do you know that what you have here is an incubator? And everybody started laughing. And I told him, do you know the cost of managing this facility? If there is no light, you cannot see the face of the patient you are dealing with. I said, who built this? All right? Who built this? You know, these are some of the problems we have. People don't look at the long-term benefits, the long-term factors management factors for that facility they are building. They just build, So, but what we can do, what can we do? I have made it a point of duty that I wouldn't say it doesn't concern me. Anytime I am passing by and I see a new building in the hospital facility, I walk in there to ask them what is happening here. Do you understand? I want to know. And luckily for me, I have basic ideas in structural design. I did a technical drawing and also had an attempt in engineering team. I thought this, so I had the opportunity to know the structural design. So I can comfortably look at it and say there's issues here. I remember when they were building a facility in the military hospital, and I made some comments that actually made them to change certain points of the design. So what we have to first of all ourselves understand what are the structural needs of health facilities, starting from what we call the rule of thumb in public health and health system. We say that the windows should have at least 20% of the total size of the wall. Starting from that, how many of us even bring that idea when we are seeing people trying to build a structure in our environment? We forget that. And when you have windows and facilities with poor ventilation, is a recipe for disaster. That's one. Then secondly, we need to start educating them and telling them, look, this facility, if it is for health system, this must be in place. And we need to have data to support what we are claiming, or references to support them. And we use people who they have their ears. We talk to them, gather them, tell them, look, that's what we call the stakeholders engagement. So by the time we start that way, and then for those ones that they have already built, they could redesign. You negotiate with the works department and explain to them what you think can be done to improve the system. So they can redesign. If it is a conduit plumbing, they can do surface plumbing from the back. We did that in one of the facilities. Then we need to places where the toilets are, where the hand washing basins can be set, and so on and so forth. And even the type of tap they can buy. You have to intervene, explain to them the kind of taps that can be utilized in health facilities, not the one that you have to screw up and down, that can't not be utilized in hand hygiene. So these are some of the things we need to start being political, all right? We don't need to say it doesn't concern me, after all, no be my money. Now it has to concern us, because at the end of the whole thing, we are the ones that we utilize these facilities. And then if we don't do something, then something have to happen to us. Because if we are going to the hospital and stay in the facilities and it is not properly done, we now are exposed to danger. All right, so we need to come back and start being political, having a way to engage with all persons that need to be engaged. And then secondly, you need to also come from within. Let people be part of, because that's what we call informed decision. You need to, first of all, educate people. Let them understand what is the direction, what is your aim, what is your purpose. Because if they don't understand it, they may be interfering, they may be having conflicts with you. They will not go with you because they don't understand what you are talking about. But when you explain critically in a way they will understand what is the need, what is the gap, what is the benefit, what is going to be repercussions, you find out that they will do the job for you. You may just sit at the back and some other person will be carrying the placard while you'll be there smiling. So I think it is a holistic thing we have to do. We have to first of all tell ourselves that it is our responsibility. We are involved. Not that it concern me. After all, they know call me when they are building, no be government money, but it concern me. That's most of what we do. But if we continue doing that, we are the people that will have the problem when the time chips are down. When people come down with respiratory acquired infection, doctors, healthcare workers, cleaners, we are the one that are exposed and not the politicians. Thank you. I think I've made some attempt on what the questions you asked.
Yes, thank you very much for that response. Then I also think most of us, if you look at our facilities, they usually have an engineering department. And I remember when we are trying to refurbish a building to create an isolation unit during the time of when the COVID pandemic started, one of the engineers did something that amazed me. he went and did a lot of research as regards IPC and structural designs. And that was how we were able to get, should I say, a structure from an old building that at least will meet standard, which is better than some new buildings coming up. So we also need to, I think, put hospital engineers to the task, one. Then maybe our hospitals too should have policies where before such buildings come in, since they are going to be in facilities, then the very important section of IPC and WASH has to be included from the design and not now having to break up walls or deface structure. So I think that's another angle we can also come in. Then I have a second question for both you and Dr. Agante. When it comes to water, most hospitals use boreholes. Sometimes, just as you mentioned, we get backups from tankers and all that. How do we go about certifying the quality of water? Because if you look at some of our assessment tools, they won't ask you that, do you provide water that is safe to drink for your clients? And there's no point washing hands with dirty water. They are still getting the infection back to the patient. So I'll listen first to you, Dr. Godian, and then Dr. Agante.
Right. Thank you very much for that one. First of all, you have to know the source of your water. If you are using tanker, the tanker would not just go anywhere and get water. Otherwise, you are sure going to have water that will be a source of infection than being used to reduce infection. That's one. Two, if you are using borehole, because borehole, yes, if it's borehole, the depth must be below the aquifer. And then at that aquifer, you find out that the water in the aquifer is usually well filtered. Okay, so the tendency of contamination like the surface well is totally different. If it's borehole, fine, it's more likely to be safe, except if the contamination occurs during the process of transmission of water within the facility. Because if you go to some facilities, you have broken pipes where anything can happen. You have the pipe that is taking fecal matter away from the toilet by the same side with the one that's carrying water, and one of them is broken and another one is broken. That becomes a problem. So continuous monitoring, it becomes very, very essential in that situation. Make sure that the infrastructure that we have is not compromised. All right. Then if you are not sure of the source of the water, then you have to have internal mechanism to clean, make sure that that water becomes safe. For instance, you have a storing tank. You can also actually measure the size of that tank and use chlorine to make sure that you put chlorine in that water and allow it to stay in number of minutes that is required or hours for that water to be sterile enough for it to be pumped. So these are some of the things you can do. So you may, in a situation where you cannot say this is the source of the water, then you have to have an internal mechanism to purify your water by adding chlorine or what we call the water guard, based on the quantity of water. Because of most of this tank, they have an inscription to tell you the size of this tank. And when you know the size of tank, you can calculate the quantity of chlorine you can put for it to make this water good enough for utilization in most of the things you want to do with it. So I think I will leave it here while my colleague can also put his voice to what question you asked. Thank you.
Dr. Agante.
Okay, thank you very much. Yeah, so for me, I would say it's about standards, documented standards. We need to have documented standards. We need to have periodic water testing. So in spite of our process, you need to be, sometimes there can be breaks in those process. There can be contamination coming from an unexpected source. So we need to have ways of periodically testing our water, whatever the source will be, whether it's being is from public supply, pipe-borne, or carried by a truck. But whatever the source is, hoping that it will be a consistent source, there should be periodic testing of that water. And then we should also have standards. And I think that's where the national program can come in to set the standards for us. You know, so for example, we say the minimum number of colonies that should grow from the water, the pH range of this water that will ensure that it is safe for use and all that. So if these standards are available and accessible, I think that will help to ensure. I hope I have answered that question well. And if I may just also use the same principle to weigh into the previous question about building standards too. Yes, so I think this really calls for a document on standards for building of healthcare facilities, whether they are primary, secondary, tertiary. So some of the things that Dr. Godian also mentioned can be, really spelled out so that if anybody needs to assess any building, at least there is a predetermined standard, which of course can be updated periodically. So I think those things, documents and standards will really help to move us forward in this regard. Thank you.
Thank you so much for those very brilliant responses. So just as they have mentioned, whenever you say leaking pipe, that is a source of water contamination. So it means the water is getting contaminated. Then we should have standards. We should have standards. And we should know the sources where we get water in case the main source of water is interrupted. And very importantly, our receptacles, how do we go about cleaning and ensuring that our receptacles are clean and we do not have biofilms? Because there are times when we've done environmental sampling and you discover that your source of water is already contaminated. So that's another thing that needs to be done. So we will need to have standards. When you have water stored in receptacles, how do you ensure that that water remains safe? And I also like the point you mentioned about periodic testing to ensure that the water is safe for use. There's a very interesting question, important question here for you, Dr. Egante, from the chat. I think from Christine Akoa from Drasa. She said, beautiful presentation. Now, what are the components of the cleaning log using University of Oyo Teaching Hospital? She feels rather than mark that cleaning has been done, that it is important on how the cleaning was performed.
Okay, thank you.
Chat has disappeared. Sorry, I've gotten the rest of the question. What are the components of the cleaning log? That is important that rather than just marking that cleaning has been done, that the log should demonstrate both knowledge and practice, how the cleaning was done, to see if the health worker applies what is being taught from trainings or reorientation done within the facility. Did you get it?
Yes, and I think I also saw that chat. So, well, yes, for now, our cleaning log is just a sheet of paper with rule lines, a table with rows and columns. So, like 31 days row. And then for the columns, we have for floor, surfaces, toilets, and surroundings. So those are just the big headings. So, and of course, then for each of those row columns, we have cleaned by and checked by. So the people who did the cleaning will sign, and the person who checked it should also sign. So, but yes, I think it's a good feedback to get that, but I don't know how feasible it will be to determine on a daily basis whether the person has good knowledge and all that. But so like I said, training is a very important component, and our target is to ensure that every healthcare worker within the institution attends at least one IPC training session in the course of the year. So hopefully this will, and up to cleaner level and health attendant level, that's our goal, if we can reach it. So hopefully during those trainings, we will highlight all these issues, take questions and all that, and to make sure the person cleaning is trained, the person supervising is trained. So hopefully between both of them, If there are any lapses, they can correct. And of course, the IPC unit on its own too does periodic checks. And even when we go for inspection, we spend a lot of time, re-educating them and making sure that they are following the protocol that has already been set. So thank you. I think that's my reply to that question.
That was an excellent response, because you brought in supportive supervision, and the fact that there's somebody that supervises and signs to check, somebody who supervised whoever cleaned also signs on the log. I think that's an important point to show that the person just didn't clean. There was some form of supervision, and if there are standards or what was the knowledge that was passed during the training, can also show that the supervisor can ensure that the person followed the protocol for cleaning. Then I think maybe doing audits, one thing one can introduce scientific methods. I remember doing a training in Lagos where they showed us the biogem, which you can put on surfaces to see whether after the cleaner cleans, the surface was. So when you now find the radioactive glow after the cleaner has cleaned, they now know that the person did not clean properly. So those are some other objective methods that can be used to show. So doing audits and supportive supervision, one can ensure that the cleaner does the job appropriately. It might not be able to capture everything on a log. There's a question here from Angeline Chotka. I hope I have not murdered the name. And who follows the work? Are there punishments? I think that maybe she did not get to put in the full chat. So if you are still on the call, you can either put it in the chat or raise your hand. I will recognize and allow you ask your question. Somebody asked a question about Sophanius on the chat, whether it's used in Nigeria. Well, I don't know how available it is in country. But, well, this is a global world now. There's nothing you cannot order for and get. I don't know if you have some other interest on why you ask whether we use Sofa News in country. Then I'm trying to see through the chat, see if there's something else. And there's a comment here. Somebody said, Mujidat Folorisho says, users such as nurses should be involved in planning or building these structures. Well, I don't know if the nursing degree gives you such a leverage, but just as he said, there should be standards. So it's important that we ensure that those standards, when we should have policies that when buildings are being set up in healthcare facilities, they should meet particular standards that will make it feasible for infection prevention and control and WASH to be instituted from the building stage. I don't know if the nursing degree gives you the leverage to ensure that you are building structures. Then somebody says, okay, I see it's still Christine. She has an issue with the quality of water distributed through water tanks. Some of the water comes from strange sources. I totally agree with you. I remember when we had the presentation on cholera, the focal person from NCDC told us that they swapped containers that were used to supply water in Lagos, and the kind of cultures they got were very wonderful. So that's why it's important that if you have a backup supply, when there's a break in supply of your main source, then something has to be done about the quality before it is distributed within the healthcare facility. Then something I also wanted to mention with you, Dr. Egantem, you talked about local production of liquid soap and other disinfectants. How do you ensure the quality of your production? If you have experience on this, please, can you share?
Yes, thank you very much. Yes, I must confess it's an issue here. We still have complaints of batch by batch variability. The bleach doesn't smell like bleach, so it doesn't smell like commercial bleach. The soap doesn't foam like other soaps and all that. So, well, we liaise with them. And recently we have been talking about maybe even getting an external, if we can send samples to an external body. We are looking at people in the university near us, if they can help us do some kind of testing and checking of this from our hypochlorite solution to our hand sanitizer, to ensure that at least what we say we are producing is what we are producing. So we don't really have a standard protocol on that yet, but it's something we are working on. Then, if I may also comment on that incomplete question about punishment. So yes, so if you look at the carrot and stick approach, I think we're applying more of the carrot approach than the stick approach for now, even though I think there needs to be some sanctions for people who are not performing. But for now, we just try to celebrate those who are performing and hope that it is a way of motivating others to perform better. Thank you.
So thank you very much for that response. It just occurred to me, Christine, would you like to throw some light on the issues you have with the quality of water from other sources? Or are you still on the call? Okay. Okay, there's another question from me here anyway. Do we have an internal monitoring and tracking unit to help monitor the standards of tank water distributed or where the water comes from? The quality of water, we need to have documentations for these too. So this is looking at it at a larger aspect. You just see water tanks distributing water. Sometimes if you go and see the source of water, you wouldn't want to touch the water that is being distributed by tanks. I think what this brings to mind is the fact that we actually do need standards that cut across all sectors, especially when it comes to water. So just as you aptly stated here, there should be monitoring and tracking. And then before water is utilized from whatever source, it should be ensured that it is safe for use. Do we have any person on the call that, okay, I can see a hand up.
Dr. John.
Yes, please.
Yeah, good afternoon. And I want to say thank you very much to our presenters for today. It's been very interesting listening, and I think this is very, very basic. It's the software and the hardware. IPC cannot be without WASH. And we all know that we still have challenges. But it's to take the challenges and then see it as work in progress. Everything can't be perfect. We had a very, very practical example with NSIC celebrating the Global Hand Washing Day on the 5th of May. An old PAC in a local community very close to Luz, they broke it down and they just had this new building. There were no hand station. Obviously, there was no advocacy to the politicians, to the management. The medical officer of health was not working with the engineering department. When we wanted to intervene to at least provide hand wash station, the engineering said, no, the pipes are leaking into the walls. So you see, it shows that, IPC has to be collaborative. Nobody can work alone. And we are working together with them, marry them together to ensure that the problem is solved so that we can provide the hand wash station outside the facility and one inside. So to me, it is very, very practical. We just came over the cholera epidemic, and then talking about checking the water quality is not just for the healthcare workers. It cuts across the hospital management, the local governments, the state governments, and at the national level. And I hear that the WASH department at the federal level is the MPACDA. I think there is high time we must have advocacy because the built environment is completely removed from healthcare delivery. We should find a way of bringing them together at whatever level so that we get the optimal results. This is a continuous discussion. It's not something that will stop during this session. We should still continue to communicate with ourselves, learn from each other. I like the experience of Uyo, where it is work in progress. And Dr. Gordian too has given us the global aspect and the national aspect. But how do we improve the data? That is what should be on our mind. How do we make it better? Yes, there are challenges. We may not be perfect, but we will eventually get there. Thank you, over and out.
Thank you very much, Ma. Good to see you after a long time. So very important contributions there. So one of the functions NSIC does is to try and see how we can bring as a front, united front for collecting qualitative quality data when it comes at setting standards when it comes to such issues. So I think that is something that we'll work on and we'll get back to the house. There's one interesting chat here from Ruben Ziragi Marcus. He says some coliform were detected in my facility hand washing soap and alcohol-based hand rub in the month of February. Please, can you share how you address this? This is what when he talked about locally produced soap, this produced detergent, that was why I asked him about how do they ensure safety and quality. Can you share with us, if you are still on the call, Ruben, what you did to address this?
Okay, thank you very much for this opportunity to contribute as well. I'm IPC specialist. I'm Nurse Ruben Marcus Draghi. So sometimes back in February, so there was a research that was carried out by one university like this. So it's from abroad. They came down to Nigeria in my facility. They took sample of and as well the alcohol-based hand rub. So after which the result revealed that there are some coliforms in our hand washing soap and sterilium. So we have to take a drastic measures because it calls for concern. Even the managers, the medical teams, the nursing teams, everybody were worried why these bacteria. These things are meant to kill bacteria, but why are they inside this soap? So we have to put some action plan. That's for the whole of the team. First of all, we have to from the health promotion team. The action plan was for them to keep on health educating the caregivers to maintain the hand washing point only for hand washing, not to be washing people. And as well, the second one is to stop discarding sloughs, that's the human secretions, that's in the sink. So we have sluice room. It was constructed so that all this secretion can go directly to the sluice, where there is a safety tank that will be disinfected. That's it's going to directly to the safety tank where the wash and dust wash team will disinfect it. So that's from the HP team, and from our own aspect, the pharmacy aspect, we check the expiring date, the storage temperature of storage, and aside from the temperature of storage, we check the quality of the soap as well. Because the way we check the quality, it's having like two different products. They are all locally purchased products. They are all purchased in Nigeria, so we test two different quality, and we found out that the one we are using, that's Oliva, it's a very nice one. So, and aside from that, there is we are trying to post check, but we're not given the permission to do that. So unless with time we will sustain this action plan. After sustaining this action plan, we are going to invite the university to come and carry out another research again. So, and we noticed that some coliforms tends to grow. That's where in a wet area. So every hand washing point, we make a hanger for the soap instead of putting the soap directly on the hanger. And according to the literature reviewed as IPC specialist, what the bacteria used to do normally, they will release biofilm inside these soaps and sterilium. So, and it takes 7 days for them to release these biofilms before they will grow inside these things this product that are meant to kill these bacteria. So we started labeling all our hand washing soap and sterilium so that it should not exceed 7 days. And in ICU, normally we give each bed with this sterilium, but we reduce it because we leave one in between each bed and one on trolley and follow up with staff to be using it, utilizing it, so that it will not exceed 7 days for them to release the biofilm inside that thing and grow within that. So that's the action point, that's the action plan we have taken, and we are still maintaining that. And we are very optimistic that there is a reduction of these microbes. Thank you.
Thank you for sharing that wonderful experience with us. I will also want to ask you, at least when you go back to the drawing board, did you find out whether that contamination was from source? Do you reuse your containers, your dispensers? And if you do, how do you ensure that they are safe before we use? Because if you look at the way hand sanitizers are produced, ideally shouldn't have organisms. The soap I can understand locally produced soap, but for the hand sanitizers, that is a cause for worry. But we can discuss this further off line so that we do not take too much time. Then I think I'm going through the charts. Am I missing? No, I can't see from here. I'm still going through the charts before. Lovely presentation. Lovely presentation. Okay. Christine says she agrees with our responses. Well done to your team in Uyo, Dr. Gantem. You mentioned that the hospital has only one IPC nurse. So she's wondering if the supervisor is the IPC nurse. I think you have also already responded to that. So awesome, awesome, awesome. Kudos to all the presenters. Quite interesting, Nurse Ruben. Somebody said he's thinking about resistance. Okay, Ruben has also said, let's have a monitoring and surveillance tool in place. Yes, healthcare workers and others, but also the clients we serve. Sometimes our clients have very powerful voices. So if you have issues, you will be surprised to know that you have clients that visit your facility that can help you solve issues better than faster than maybe your management might be able to do. So it's important that we should think about forming patient support groups because they are the ones that use the facility, and the facility is meant to actually make them happy and safe. Then Amaka, should I let you take the announcements? Okay, yes, Amaka has shown us our certificates of recognition. Dr. Godian Chibuezezema, we are very happy and pleased with you sharing knowledge with us at this session. So this is N6 presentation, acknowledging your contributions. Can we have the second one for Dr.
Thank you very much.
Agantem?
I appreciate this. I'm really glad.
Can we have Dr. Agantem certificate of appreciation?
It's up.
I'm seeing Ezima's own. No.
Okay, possibly network,
I'm
but it's
seeing
okay.
Okay. It's okay. So we'll just like to let the house know that yes, ICANN West African Hub has a presentation tomorrow. I think we've shared the links on monkeypox. Anything you need to know about monkeypox, a talk that is being given by Professor Adebola Olayinka with WHO Afro. I think it's at 10 a.m. tomorrow online. We have shared the links on some of our platforms. So we will still share again in case you have missed it earlier. Then this is just to let the house know that we are planning a conference. Our last conference was virtual, and a lot of people insisted that at least wanted us to have at least a hybrid conference so that they could have physical opportunity to be there physically. Then for those who can't make it, can attend virtually. So we are planning a hybrid conference this year. It's going to be in the first week of December. Details will be shared with all of us as soon as possible. And then Dr. Godian took us a bit through the WASH Fit tool, but we also think it's important that we know how to assess WASH facilities, WASH infrastructure in our facilities. So we'll be following up next month, our usual time, last Thursday of the month, which was on the 26th of September, with a little more detail on the WASH Fit. How many of us are familiar with the tool in-house? Can we see by show of hands? How many of us are familiar with the WASH Fit? Can we see by show of hands? I'm not seeing any hands up, or is it I'm not being heard?
We can hear you.
Okay,
Yeah,
I
but
was
it's
And maybe next time you just use the poll so you see the percentage.
okay, but I can't even see any hands up.
Next time.
Oh, there are about 3 hands only.
3
Okay,
hands are
about
up. Yes.
okay.
Yeah.
So then make it a date with us. Next week we'll delve into what the tool is about and how it can be. I said next week, sorry, next month, and how the tool can be used. So Chiamaka, you have anything to say?
Okay, nothing else from my end. Just to reiterate that we're looking forward to the annual conference coming up in the first week of December, and then we'll share more information about that. Thank you.
And thank you all for joining us. Don't forget about the feedback. You have to give us
Okay, I
feedback
always
to make
forget about the feedback.
they share the feedback link so that we can make it better. And if you have any other suggestion, you get in touch with us. If you are not
Okay.
members of NSIC, please join us. We'll send you requests. Thank you.
Thank you very
Okay.
much, everyone. I
Thank you
appreciate it.
so much. I was going to say, okay, he said they do not refill container. So next week, I keep saying next week, sorry. Next month session, we will delve into using the WASH Fit tool. So please make it a date with us. And I want to thank everyone that has made it to today's session. Please remember, we know that we have a WHO has said monkeypox is now an emergency. So let's try and listen in on tomorrow's presentation to learn all we need to know from Professor Olainka on monkeypox. So looking forward to seeing all of you next week. Please remember to use to fill the feedback link so that we can improve our sessions. Thank you all.
I also want to add something.
Thank you to our presenters who gave us very interesting information. Yes, Amaka.
One more thing. Yeah, thank you so much. Okay, so I also want to encourage all members to renew their membership fee. Yes, because the membership fee covers for ICANN fee too. So it gives you opportunity to trainings, workshops, and all of that. So we're encouraging everybody to pay their membership dues as we can. Thank you so much.
So John Solomon, the time for tomorrow's presentation is 10. So we'll still share the notice on the meeting. It's 10 a.m. tomorrow. I think the time is right, Abaka? 10 a.m.
Yes, it's 10 a.m. 10 a.m.
Okay. So we'll still share the link for tomorrow. People are asking about slides. So Amaka, what do we have to say?
Okay, so everyone who is registered will get the slides. We're going to share the slides before the end of the week.
So please, a point of reminder, please register. And also register on the platform, the NSIC Echo platform, so that you get regular updates. You get notifications about meetings when they're about to come. If someone is asking for the feedback link, please can we reshare?
All right, Alina will share that now. Okay.
And thank you all so very much. Thank you, Mujidat, for appreciating us.